Hello and welcome. I'm excited about our show tonight because we're talking about a big topic that I think affects almost all of us. We're going to talk about sleep, and with me is a behavioral sleep disorder specialist from the Minnesota Regional Sleep Disorders Center. Samantha Anders is with me. She's a licensed clinical psychologist, and I'm going to ply her with questions. I learned that probably 30 to 40, maybe even 50% of adults in our country have sleeping problems, at least for sure at some point in their life. And so we're going to talk about different problems, ideas that Samantha has for coping with them, all kinds of interesting facts and figures. So welcome.
Thanks so much for having me.
Oh, you're so welcome. Am I correct, 30 to 50% of adults, is that in fact true?
It's pretty hard to estimate because lots of people have these problems and never talk to anybody about them. They're so common. But I think that seems like a reasonable ballpark estimate for sure.
Mm-hmm. And it doesn't always mean that if you have problems at one age, you're going to have them your whole life, though, does it?
No, absolutely not. Mm-hmm. Yeah, some of these things, particularly insomnia, can be kind of transient, and you can get better and never have a problem again, or you can have the problem periodically.
Mm-hmm. I have some relatives who seem to have the long-term chronic insomnia, and that's a very, very hard thing for them to deal with.
Absolutely, it's a very challenging problem.
And there are health effects, too, that aren't so good from constant sleep deprivation, aren't there?
There can be. I mean, it can be pretty complicated. It sort of depends on what's underlying the insomnia, if it's really just insomnia. So we think of insomnia as any problem falling asleep, staying asleep, or waking up too early, or feeling unrefreshed from sleep. And chronic insomnia we define as something longer than, a month, several nights a week for longer than a month. It starts to really affect your functioning. And so people will often report, and we do know that it's true, that you'll have delayed reaction time, or your concentration won't be as good. Kind of those effects, short-term effects of sleep deprivation.
I read somewhere in preparation for our interview that it's a public safety issue too, because of the truck drivers who are sleep deprived, or anyone who's sleep deprived who's behind a wheel. And I hadn't really, of course I'd heard that, but I hadn't really thought of it as a public health issue. But it certainly is, isn't it, when you think about that part of our society and life?
Absolutely. I mean, and they've done a lot of research, and people's reactions times get much, much slower, but they'll still perceive that they're reacting just as quickly. So it's something
they're not aware of it.
Exactly. It's something that people can be impaired and they're really not aware of it. We're very bad at understanding that about ourselves.
Oh,
yeah.
Very interesting. Because we do tune in ordinarily quite well to our reactions, it seems, but maybe not as well as we think.
Not as well as we think, apparently.
A little too cocky there. Men versus women in terms of sleeping problems. I've read that women have a lot of issues regarding sleep tied into the menstrual cycle, premenopausal years, the menopausal years. So does that mean women have more problems in general?
Women definitely have higher rates of insomnia, pretty significantly, and partly it's probably hormonal. The second most common symptom of perimenopause is insomnia after hot flashes. So I see a lot of women who are either in menopause or have just had trouble sleeping since then.
Okay, so women more than men though overall?
Well, I mean, so it depends on what we're talking about for sleep problems.
Okay, right.
So because there's many different kinds of sleep problems. So I treat primarily insomnia is my main specialty, but certainly see other things. And in the clinic I work in, we see all different kinds of sleep problems. And I'm not sure of the prevalence in terms of gender differentials
okay.
for all of the other sleep issues we
Probably
have.
hard to measure because of self-reporting issues for one
Exactly.
thing, right?
Exactly.
Your specialty, I just thought it'd be fun for people to know a little bit more about what you do as a behavioral sleep disorder specialist.
Sure.
What does that mean in terms of your professional life?
Sure. So I work at the Minnesota Regional Sleep Disorder Center at Hennepin Health Care downtown Minneapolis. And what that means is that typically patients will come and they'll see one of our physicians or a nurse practitioner, and they will assess them for kind of all sleep disorders, and they fill out a bunch of questionnaires. And if there's a behavioral component, so things that they do that contribute, they will often refer them to me.
For example, what would be a behavioral?
So what we know is that insomnia often is largely a behavioral issue. So, and there's lots of research on how to best treat insomnia, and cognitive behavioral therapy for insomnia is actually the gold standard treatment. So patients prefer it, you get better and more durable outcomes, and it's very challenging. So most people for insomnia are treated with a medication, typically in primary care. And what we know about medications is that basically no sleep medications are really intended to be used for a long time.
Right.
A lot of them lose effectiveness over time. Sometimes people can use escalating doses. Of course, sometimes you have weird side effects. Everybody's heard about the Ambien driving
Right.
or doing strange things. And that's, just a small number of people that have that, but there can be some weird side effects, or the next day people might not like how they make you feel. And so if we can choose, we would choose to have insomnia actually treated by someone who looks at sort of what are the behaviors you do around your sleep, and how do you think about your sleep?
So the rituals prior to sleep? Or,
That's a component of it.
okay, but not all
Not
of
the
it.
whole thing,
Okay.
yeah, but it definitely is a component of it. So part of it is thinking about how do we harness your body's natural ability to sleep. So for instance, often what will happen if people have trouble sleeping, and often so everyone has trouble sleeping in terms of insomnia at some point. It's our humans' terrible adaptation to stress is that we don't sleep. And that makes sense if you're, hiding from bears out in the wild.
Right.
If you're stressed out, you don't want to go to sleep. That's not a good time to sleep.
The
But
fight, flight
yes,
thing, right?
you want to run away,
Be
right?
ready to run at
right.
least.
But now, since most of us do not live in that situation, actually, when we get stressed out and we don't sleep, it's like really, really ineffective. But that's sort of what we do. So basically, everyone has short-term intermittent and stress-related insomnia. And when that happens, you have a couple of really crummy nights and you have to go to work. And it's the weekend and you say, oh, well, I'm going to take a nap because I'm so tired, or I'm going to go to bed really early. But kind of once insomnia starts, sometimes it can kind of have a life of its own. And if you go to bed really early, but you're still keyed up about something, you might sleep just for a couple hours and then be up for a couple hours in the middle of the night and then sleep a couple hours, and you still don't feel good. So then the next day you take a nap. But if you take a nap, it means you're less tired at bedtime.
It's a vicious circle, isn't it?
It's a vicious circle, yeah. So that could be one example of some of the behavioral components. And most people, it's really hard to see that when you're in it.
Do most physicians who are referring people to people like you at a sleep center, do most feel we don't want to put people on meds, or are meds still the first go-to tool for most doctors who see people in primary care?
Probably meds are the first go-to.
Okay.
I also used to work in primary care at Hennepin Health Care, and part of what I would do is try to provide some information for the primary care doctors. Primary care doctors are seeing 8 million things. That's one of the hardest jobs in the world, I can only imagine. And people complain about insomnia, and so they say, well, this is an easier Here's the tool that I have. So they might not even know that this other stuff kind of exists, or they might not have access to someone who does that. They certainly don't have time to counsel people about that.
But as the patient, one of the things we should probably start saying to a doctor is, well, what about sending me to someone who would be able to look in a more total way?
Yeah, if
And
you're a
maybe
patient, you can advocate for that, for sure.
Advocate to not, go on meds as the one and only solution.
And sometimes the use of meds is very appropriate. So when I would see someone in primary care and they were having insomnia, let's say there was just a death in the family or something kind of traumatic happened, I would often sort of talk with the primary care doctor and say, short term, let's help this person get some sleep, as long as we know that that's not the long term solution.
Situational kind of a thing, yeah.
Yeah, does that make sense? Or like you go to the hospital and often people have screwed up sleep or they're in pain or things like that. There's lots of reasons, very appropriate reasons to use sleep meds. I think just unfortunately people will end up
getting hooked and then having less success, really, I'm guessing.
Well, and part of the problem is that once you think you need sleep meds to sleep, you do. So there's the psychological sort of dependence component of that. And that's part of where the cognitive piece of this intervention comes in. Sort of what do we believe about our sleep?
And how can we change what we believe?
Exactly. I think of it kind of as sleep confidence. So when you have trouble sleeping for a long time, some people will tell me, I just had a patient tell me today, when I think about sleeping, I dread it. And if you do that, you have a lot of anxiety that becomes associated with bedtime, even thinking about it during the day. And in fact, your bed actually becomes associated and becomes like a cue for being awake. So there's this Pavlovian sort of unconscious learning piece that comes along with it.
Interesting.
It is fascinating.
So the psychology in terms of sleep is very key, isn't it?
Absolutely.
Very key. I want to go to a little more of a measurable thing here.
Sure.
The stages of sleep. We used to think there were 5. Now we say there are 4. They've combined a couple stages. And can you just briefly go over the 4?
Sure, sure. So stage 1 sleep is kind of the sleep where you're just drifting off and you're still a little bit aware of the environment. And this is sometimes people will have like hallucinations a little bit during that time, or sometimes people will feel like they're falling a little bit.
There can be that jerk response.
That jerk, yeah, it's called a hypnic jerk.
Yeah.
Yeah. And then stage 2 is sort of a in-between stage of sleep, and that's usually pretty brief, 20 minutes or thereabouts. And then we have stage 3, which is a little bit deeper sleep, and stage 4, which is your real deep sleep.
And that's the Rem sleep, isn't it?
No.
No.
So Rem sleep comes after stage 4, and Rem is a light stage of sleep. That's your active dreaming stage of sleep.
Oh, okay. So then we would have 5 stages according to this model.
I mean, one of the things I think that's so fascinating about sleep is that we don't know much. We're always learning new things. And so, who knows? We might find out something brand new next week. Who knows?
Well, that's also why it must be an exciting business to be in.
Oh, it's fascinating.
Yeah.
I'm always learning incredibly interesting things.
So the REM sleep, though, that's when we dream. I read that it can be as long as an hour long.
Well, so you
Is that
actually can
correct?
dream in all stages of your sleep, but the really active dreaming tends to happen in REM. And that's when your muscles are paralyzed to help prevent you from acting out your dreams. There's actually a sleep disorder that was discovered at the Minnesota Regional Sleep Disorders Center called REM behavior sleep disorder, which is where people act out their dreams.
And get up and might do something
Yeah, or
dangerous.
sometimes they'll kick out or punch out, or they might fall out of bed. So it can be a scary condition.
And that was defined at the Minnesota Center.
Yeah.
Oh, interesting.
Yeah, there was just a book that came out from Carlos Schenk is one of the doctors. Yeah.
Right. Oh, interesting. And so that would be, it's a fairly uncommon phenomena, though, isn't it?
Oh, very uncommon, yeah.
Yeah, okay.
But it is treatable, so if that's something that happens for anyone, they should definitely ask to be referred to a sleep clinic
Okay.
and talk about
That's good to
that.
know. And this stage model, we repeat that several times in the night, right?
That's correct.
It doesn't, one set of the 5 stages is repeated over and over, depending on how long we're sleeping,
Yeah,
I guess,
so those
right?
5 stages together typically for an adult are about 90 minutes, and we call that one cycle. And then what you do is you go back through, so you go to Rem Sleep is typically the last state part of that, and then you start again at stage 2, 3, 4, and then you go back to Rem. And over the course of the night, how long each of those stages are changes. So at the beginning of the night, you don't have very much Rem sleep, and by the end of the night, you have a lot more Rem sleep.
Okay. In terms of the dreaming state, and that's the REM state, dreams are something that it could be a whole nother topic.
Oh, certainly.
But they're important. I mean, it's important that we do dream, isn't it? Isn't that a sign that we're getting a good night's sleep?
This is one of the fascinating things. I don't think we really know.
Oh, okay.
I don't think we really know much about dreams at all. I mean, people
So
have a
this
lot
might
of...
be a myth.
Yeah, people have a lot of, certainly there's like whole fields of psychology that were related to, there's a very famous book called The Interpretation of Dreams by Freud.
That's right.
But we don't really know what the purpose of dreams are necessarily. I certainly hear some of the sleep people I work with say, it's just kind of like your brain misfiring and that's all it is. And then there's also, we know sometimes dreams can be very impactful. So one of the things I do with people is something called Imagery rehearsal therapy. So if someone has typically trauma-related dreams, so dreams that are recurrent and tend to be pretty similar, sometimes exactly the same dreams, sometimes just very similar dreams, there's things we can do to help them try to change their dreams by having them kind of rewrite
If
it.
it's a disturbing dream.
If it's a disturbing dream.
Related to stages, I guess, the new Fitbits are saying that they measure your sleep. And what do you think about the accuracy of those?
So they've actually done a lot of research comparing a lot of those wearables and not very accurate. I think the technology, I have no doubt that technology will get there, but right now they're not very accurate. So I usually tell my patients to not wear them because it tends to make them more anxious about their sleep because they say, oh man, I only got, 45 minutes of deep sleep last night, and it doesn't know. It's not true. It's very good for tracking steps. I suggest you keep it at that.
Okay, well, that's good to know. That's very good to know. I wondered because they don't cost that much, and I'm thinking
We're
it'd
not
be hard
quite-
to be really accurate.
Yeah, we're not quite there.
We only have 10 minutes left, Samantha. So I'm going to throw just a bunch of smaller type questions at you.
Sure.
And maybe get a short response, and we'll see how many of your curious questions I can ask you. Alcohol. A lot of people say, well, I'll have a nightcap. And it's probably not, though, going to help our sleep, right?
That's correct. So alcohol might help you fall asleep. It's very good at helping you relax, but it does disturb your sleep architecture, so kind of those stages of sleep, and it might promote waking up a lot more in the middle of the night.
Okay, so that's important to know. Night owls versus, what's the morning?
A lark?
The lark, that's it. Are people biologically programmed to be one or the other, or do we get into a habitual thing with our sleep in that sense?
Both.
Both, okay.
So people can have real preferences, and sometimes, like I'll see patients, this is a part of a behavioral treatment too, someone who, since they were a baby, would not go to sleep until much later than like a regular baby. I've got a baby at home, he goes to bed at 7 p.m., wakes up at 6. But some people, since they were infants, would have their schedule be totally different. And that's what we call a night owl or a delayed phase circadian rhythm disorder. So there is a kind of biological hardwiring piece of it, and often it will occur in families, so there's a genetic component. So like, I'll meet people and they're like, yeah, our whole family, we all go to bed at 1 o'clock in the morning and always have and sleep till 10 or whatever. And we can influence that by our behavior. So there's a lot of variability in this. So if someone has a clock that naturally would say, I'm sleepy at 3 a.m., and I wake up at 11 a.m., it's much harder to switch from that to then being someone who's at work at 8 o'clock in the morning. So it can be a real issue, but you can also influence that by getting up at the same time every day.
So if you want to change
If you want to change it, but it's pretty hard to move your clock much more than we think, maybe an hour or two.
Really?
Yeah, so it's actually a real quality of life issue for some people.
I had an interesting thing, just personally, I'll share real quickly. I used to go to bed pretty regularly at about 11, got up about 7, nice, normal. And then I was married and my husband died suddenly in the middle of the night. And really from the time of his death, I started not wanting to go to bed at night until I was so tired that I just had to crash. And I've tried to move back to that 11, but it's been really a challenge. And that would be not a biological thing, but more of a psychological.
Yeah, this kind of conditioned thing, and that totally makes sense to me. I mean, what a scary thing to have happen. And then everything about your normal sleeping routine is disturbed, right?
Right.
And so that's exactly the kind of thing that
I'm thinking
might
that's
be
kind
able
of an
to.
example,
That's
isn't
totally an example. Exactly.
And I've been able to work around it, but I would ideally like to get back, but you know, it's been an interesting challenge. Someone in my crew, on my crew tonight said, be sure to ask her about melatonin. When we talk about sleep aids, sleep meds, melatonin isn't a medication per se, but it's in that camp, right? What do you think about that? Because it's, I understand, not addictive.
Well, melatonin is considered in the United States a supplement, which means it's not regulated by the FDA, which means no one's checking it.
Which is probably a red flag
Which
thing
is
for
a
you.
problem. And so they've done I've read some studies that they've looked at sort of the quality of like what is in melatonin. And there's a lot of other stuff that can be in melatonin. So that's one thing that's really important to know. So even though most people don't get side effects from melatonin that we know of, we actually don't know what happens if people are taking melatonin every night for many decades. And especially when we don't know what's exactly in it.
Are there certain brands, you probably can't give us a brand, but are there certain brands that would be a higher grade, more monitored, responsible company?
That's a good
make it?
question. And I had at one point, I cannot remember the name off the top of my head, of like one that had better quality. I certainly can share that with you later. Melatonin can be very effective for certain things. So melatonin is something sometimes we use to help someone try to shift their circadian rhythm a little bit. Sometimes it can be effective in some other sleep disorders. It can help people fall asleep sometimes a little bit faster. It doesn't do much for people staying asleep. So I'm always a little bit leery of like anything you're putting in your body. I think it's good to kind of know what the research is and that kind of stuff.
I can hear your cautiousness. And
yes, absolutely.
Gives me pause. Cough syrup. I had a horrible cold a year ago, and I slept like a baby because I think the cough syrup ingredients. But I'm guessing, again, that's not something one should get too used to, right?
No. I mean, it's certainly, again, not indicated for long-term use. And it can interact with other medications you're on. And some people actually have it, like about 30% of people have a paradoxical effect to cough syrup. And so they'll actually become very hyper.
Ooh.
Yeah, so it's not doesn't always work.
Yeah, that's good to know. I'm getting the cue that we need to give people some resource information. So we may have time for one more question,
Oh my
but
gosh.
Would you like to give us the website for the Minnesota Regional Sleep Disorders Center?
Sure. So hennepinhealthcare.org. And if you go on there, you can look up the sleep clinic, and that will bring you right to the Sleep Disorder Center.
And then you said that there are some apps that you have found really helpful that you, can you explain just real quickly?
Yeah, so
How to-
some people, if they want it, for instance, for insomnia, if that's something you struggle with, there are some online programs that you can use that actually have some good research evidence. And so there's one called Learn to Live that's actually was developed here in Minnesota by a team of psychologists I know, and they have an insomnia program. And I did do a little work on that, so I know that I think it's good.
Okay, and you'll give me a website. We'll
Absolutely.
insert that. You'll see it.
LearnToLive.com.
Well, thank you so much, Samantha, for coming down and shedding all kinds of light on this very complex topic we're calling the show Mysteries of Sleep.
Okay.
It's an apropos title with all the unknowns yet.
Well, thank you very much for having me. It was very fun.
Thank you for being with us. I'll be back again next week. Until then, have a good week and get some good sleep.